Welcome to the American Society of Plastic Surgeons Roundtable panel discussion. I'm Caitlin Clark, and I'm joined by four renowned plastic surgeons and ASPS members. Dr. Lisa Casalith, who is a plastic and reconstructive surgeon in Beverly Hills, California, who specializes in corrective cosmetic and reconstructive breast surgery. She's the past chief of plastic surgery at Cedars-Sinai Medical Center and a leader in the field of breast revision surgery. Dr. Mia Talmor, a New York City plastic surgeon who specializes in complex breast revision and reconstruction and has distinguished herself in the scientific community through her research and publications. Dr. David Sahar, a plastic surgeon who practices in Sacramento, California with a focus on reconstructive procedures and has published more than 50 research papers and scientific articles. Dr. Leslie Cohen, a reconstructive plastic surgeon based in New York City, specializing in breast cancer reconstruction, particularly in using your own body tissue to reconstruct your breast, as well as implant-based reconstruction. She's also an assistant professor at Weill Cornell Medical Center. I'm also joined today by Jen Rosenbaum, a breast cancer survivor who lives in New York City. And we're all here today to discuss everything you need to know about breast reconstruction procedures. To kick us off, let's start with all the different types of breast reconstruction. Dr. Sahar, you're one of the go-to breast reconstruction surgeons in Northern California. What are your reconstruction options after a breast cancer diagnosis?
Thank you, Kate. It's good to be here. Today, we have great options for breast reconstruction after breast cancer surgery. These options continue to grow and improve through research and science. And the risk of complications continue to go down as we better understand the disease process and improve our techniques. The reconstruction goals basically are to restore form and function and renew self-confidence and comfort and eliminate the need for external breast prosthesis. And depending on the kind of breast surgery that is performed, multiple options are available. And for instance, for lumpectomy defects, an oncoplastic reduction with fat grafting may be the appropriate procedure. For mastectomy, whether it's unilateral or bilateral, the timing can be immediate, staged, or in a delayed fashion. And the reconstructive procedures themselves can be performed using implants to form volume or autologous tissue, or a combination of autologous tissue and implants. Or the patient may opt for no reconstruction at all. And the implants come in different forms, including saline, gel, texture, smooth, shaped, round. And the autologous tissue that is used, it could either be pedicle or a free flap, or that involves microvascular surgery. Now, microvascular surgery would entail a bigger investment both in patient and surgeon part. It's a longer procedure. It requires hospital stay, but you're using your own tissues. And the tissues that can be used, it could be an abdomen, thighs, buttock, back, and it's a great procedure for certain situations such as post-radiation, where the skin pliability is not very good. And for pedicle flaps, the workhorse for plastic surgeons, it's the latissimus dorsi myocutaneous flap. And of course, fat grafting, where fat is harvested from a donor site, such as abdomen, processed and injected into breast for volume.
Great, thank you. Dr. Cohen, would you explain what a breast flap procedure is and who it might be best for?
Sure. So typically a breast flap implies that we're taking one area of tissue, meaning typically these days it's your skin and your own fat, and transferring it to the breast region to reconstruct the volume of your breast. And what that means is that in order to take tissue or fat or skin from one area, you have to take an artery and a vein, meaning the blood vessels that deliver blood to that skin and fat that keep it alive is typically harvested with the fat and skin, and then those blood vessels are connected 2 small blood vessels in between your ribs typically, or under your arms, under a microscope, so that there's always blood flow in to your body tissue that's been transferred and blood flow out. So a flap implies that you're taking tissue from one area of your body with its own blood supply. And the goal of that is so that it stays alive with you, sort of like a transplant. But instead of it coming from elsewhere, it's using your own body tissue, and your body's not going to reject that because it's your own. The goal of that is to basically give you a reconstruction that is nice and warm and soft, feeling like your own fat may feel. And on top of that, it lasts forever. So once it heals in, and the swelling goes down, it remains as nice and soft as your own, say, belly flap or thigh fat or anywhere else on the body where we may have taken tissue from. 90% of the time it's from the belly or abdominal region. But the nice part of that is that it's permanent. Unlike an implant, which may have to be changed out over time, or an implant that could rupture or leak or break, once a flap heals in, it's essentially with you permanently forever. As you gain weight, it may get larger, and as you lose weight, it may get smaller because the fat is metabolically alive.
Got it. So does it look and feel more natural than an implant, or is it the difference kind of subtle or negligible?
I would say the difference is extremely large compared to an implant. So I would say if you feel your own belly fat, essentially, it's, in general, it's nice and soft and mushy, for lack of better words, but that is very hard to recreate with even the best implant. So I would say if you're going for the most natural feel, then using your own belly tissue is a great option if you are a good candidate. It does come at the expense of additional surgery in an additional site on your body and additional scarring.
And what does that surgery look like when you're taking it from the belly?
It's very similar to the traditional tummy tuck or abdominoplasty, where if you're having what's called a deep flap, then you're typically left with a linear scar that is usually about hip to hip, just like a tummy tuck would be. And then in addition to that, you typically would have a small scar around your belly button, that is exactly the same as if you were to have a tummy tuck scar.
Okay. And what's the percentage of people that you say opt for this over an implant?
I think that the percentage ranges across the country, because of what patients are actually exposed to in terms of their options. Whether they're in a large urban center where there's more plastic surgeons who perform flaps on a more daily, weekly basis, those patients are probably getting offered flaps much more often than if they're in a location where that kind of surgery, which is a little bit more complicated, is not offered in a smaller center. So of all comers in the United States, implant-based reconstruction by numbers is much more common, but I think it really depends on what individual provider you're seeing and what their personal training is.
Wonderful. And Dr. Kaselith, are certain breast reconstruction options better for different patients?
Absolutely. I think there is not a plastic surgeon that won't say, boy, you really have to look at the patient. And, a tiny little A breast is very, very different than like a very tonic double D. And so you might treat those patients very differently just because one, the larger breast or a radiated breast from a prior lumpectomy is going to be much higher risk. So in my practice, I tend to kind of get an idea who I'm talking to first. Like, am I talking to somebody who wants to be small breasted, might be happy with a flat closure, flat aesthetic closure, or something called the Goldilocks or swim procedure. These are all tissues that use your leftover parts on the breast alone after a mastectomy to make a breast. Am I talking to someone who is going to be happier with a simple inframammary crease that's under the breast incision, where we'll do an implant-based reconstruction, or it's someone who really insists on using their own tissue, and why? So those people are handled very differently. So because I don't do a lot of flaps anymore and I refer those out, I especially kind of take the large breasted, high risk patients. These are patients often with radiation histories. If they don't want to be too large, especially they want to have a reduction, I'm almost always performing what's called a swim flap. Others may know this is a Goldilocks flap on that. I wrote a paper on this with Heather Richardson, who is a general surgeon, a breast surgeon. And what we do is we'll use the patient's left, like you can imagine you have a mastectomy. If you leave the nipple, areolar complex and skin, you've got, even without the breast, you've got a lot. So you can use that to make a smaller breast. So those are my very high risk, largest patients. If it's a large patient, like a D-double-D, especially if they're ptotic means droopy, I'm usually doing a direct to implant with mesh, something called Galaflex mesh. It holds it up, doesn't let the implant sag. It looks very, very nice and is a very low risk in terms of something called seroma, which is higher for those patients. And then finally, for my small or medium breasted plate patients who want an implant-based reconstruction, I go over the muscle, direct to implant with something called ACell or dermal matrix, which is a naturally based human cadaveric skin tissue that gets absorbed by the body, by the patient's body, and it stays soft and resists contracture. So in all patients, for my own practice, I have a one and done kind of step technique. Patient can come back for additional touch-ups or for additional surgery, but they get off the table without a tissue expander, with an implant, or with a no implant-based reconstruction. You know, and the question is, of course, is like, you know, of the patients that want a natural tissue reconstruction that would be too small with a Goldilocks or swim, what do we do with those patients? And those patients can choose to have a implant placed temporarily and then go for the reconstruction with the flap later. Or alternatively, they can go somewhere where they'll do it both at the same time.
And why would someone want to use their own tissues versus an implant? What are the benefits to using your own tissues to create a breast?
Well, I mean, it's pretty obvious, right? It's like you don't have any fake parts. Everything's real. There's no part of your body that's under warranty or might leak, right? So that's always, well, there are parts that might leak, but not the silicone implant. So, you know, that's always the nice idea of it. The problem from a practical point of view as a plastic surgeon is that, and I think something that needs to be said, and so I'll say it now, the reconstruction, first of all, can only be as good as the mastectomy flap that the general surgeon makes. Okay, so we are very important, but the actual result is very limited by how good the mastectomy is, right? So that's something to remember as we do all of this. So the reason I bring this up now is because if you're working with a surgeon that doesn't do a very good mastectomy, you might have to remove tissue. Really, some of those surgeons, you know, there was a case where we would be doing latissimus flaps on every single patient because of the degree of skin that would be removed at the time of surgery. You know, alternatively, if I'm working with a mastectomy surgeon who makes an inframammary crease incision, scoops out the breast, and literally leaves perfect skin and subcutaneous fat intact, I can put an implant in there one stage. I don't make a cut any other location. The surgery, my part of the surgery, will take me as most as 1 hour per side max. I'm working at the same time as them as they're performing the mastectomy. Then you have this wonderful synergy between the plastic surgeon and the mastectomy surgeon, where we're really being efficient, we're limiting the surgical site, and we're creating the best outcome. If the patient down the road says, oh gosh, I don't like the idea, I need fake, you can then at a lower risk time at a secondary procedure, if you don't like the implant, it's not working for you, do the flap reconstruction. So, you know, I encourage my patient to like, let's take the no, let's not burn any bridges right off the bat. And then if you love the reconstruction, you're done. And if you still want to do like a bilateral deep flap where your abdomen is split and put in your, you know, breast tissue instead of the implant, that option is still open to you down the road.
Is that common, having both surgeons work in tandem?
You know, it's a norm in my practice, and I do irritate the crap out of the breast surgeons because they want to like stand on my side, and I'm like, but for me, if I can cut an hour off my surgical time and my patient's having the surgery done within 3 hours instead of 4 or 4.5, like if I were the patient, I would very much want to do that. So, you know, I get to choose it because I'm old enough who I work with. So I only work with people who work for the patient. And so it's the luxury of like being in business for years. And, you know, and then I think patients should really often choose their plastic surgeon first. You know, you're in New York, you know, you're going to Dr. Talmor, ask her, who should I go to as my mastectomy surgeon? Ask Dr. Zahar, who should I go to? Because they'll give you the person who is going to do the best job at removing the breast tissue without injuring the blood supply or the subcutaneous fat that they can work with. That shortens the case, decreases your risk rate, and increases efficiency.
Wonderful. Thank you for that very thorough response.
I would like to add, echo Dr. Kessler's note about the oncologic surgeon, the importance of it in our work. We're all, this is a team effort, and everyone needs to do their part to get the optimal outcome. And if the skin flaps are very thin, there's a high risk of wound dehiscence, wound breakdown, infection, and ultimately, potentially, implant exposure. And that's really hard for both the patient and the plastic surgeon. So ideally, it would be great to work with a trained breast surgeon who understands the intricacy of what we deal with afterwards, so that they leave good flaps with at the same time minimizing recurrence of breast cancer.
Dr. Talmor, you perform many breast reconstruction surgeries each month. Would you say that the majority of breast recon surgeries are performed as an immediate procedure after a mastectomy?
I mean, I would say almost all. So in our breast center, every patient who is diagnosed with breast cancer and thought to be a candidate for mastectomy, which is essentially everyone, because a mastectomy can be a choice even in more limited disease. So I would say that nearly 100% of patients are referred for plastic surgical input at the time of their diagnosis with breast cancer. Once they're diagnosed, you know, and we discuss the options, we almost always offer an immediate procedure at the time of the mastectomy. Now, that's not to say that that immediate procedure is the last procedure. So we still consider that obviously immediate. When we're doing a staged procedure, which is to say that we put a temporary implant in or a tissue expander and then follow that up with a permanent implant, we still consider that immediate because we're starting the process immediately at the time of the mastectomy. And the important point there is that at the time of the mastectomy, the skin is at its most, theoretically most pliable. Often if we've done a total skin sparing procedure, there's a lot of excess skin, and we don't want that skin to tighten or contract. So we want to take advantage of the fact that there is that relatively fresh skin at the time of the reconstruction. So even if we're just starting the reconstruction in a staged manner, we want to start that immediately. I'd say that the only circumstance in which we're delaying the reconstruction at the point of the mastectomy would be a circumstance in which we thought perhaps that the skin, as has been described before, doesn't have adequate vascularity. And in that circumstance, we might say, oh, it's not safe to start the reconstruction now. We'll come back in a few weeks later once that has healed, and we can start then essentially. But I'd say that that's an almost never occurrence if you're working with breast surgeons who you're familiar with who have experience doing the mastectomy.
Mm-hmm. So there are no benefits to a delayed recon procedure?
Well, you know, I think the traditional sort of lore was that if someone was going to have radiation, and that we knew that person was going to have radiation, then we should delay the reconstruction again so that the flap, the tissue, which is what we normally use in a patient who has radiation, the flap is not injured by the radiation as well. So we want to deliver the radiation locally, but not to the distant tissue that we'll ultimately use to reconstruct the breast. That being said, I think more frequently now, because we are doing these skin sparing procedures, we don't want to remove that skin to have things sort of heal flat. So we'll put a temporizing implant, a tissue expander in, have the patient get radiation, and then come back in at a later date and replace the tissue expander for a flap, essentially. So while the sort of traditional lure was to do a delayed flap reconstruction for someone who is expected to have radiation, that really has changed. And now we still go ahead and start those reconstructions immediately.
And for those who don't know, would you mind explaining what an expander is?
An expander is a temporary saline-filled implant. We place it at the time of the mastectomy in a similar pocket that we place the permanent implant. We actually build the pocket to the extent that we can around the tissue expander. The advantage of putting a tissue expander in at the time of the reconstruction is that if there's any compromise to the skin, if it's been traumatized or devascularized in any way, it's a bit safer to put something that's flat, that doesn't put any pressure on the skin as it heals. So we can use that tissue expander to ensure a bit of safety in a circumstance in which perhaps the skin is not as robust as we would like it to be. There are other subtle advantages. Sometimes I'll use a tissue expander, for example, in a patient who is large breasted, but who is hoping to be smaller down the road. In that circumstance, I might put a tissue expander and let the skin contract around the tissue expander, tighten a bit. And in that circumstance, we often get away with just changing out for a smaller implant without having to do any manipulation of the skin, any lifting, which can increase the risk of vascular compromise, but also can leave visible scars on the skin. And, you know, if we're coming in, for the most part, we do our incisions underneath the surface of the breast. So the vast majority of women who are coming in for these types of total skin sparing procedures don't have any visible scars on the breast. So it's nice to be able to leave them without scars on the breast after the fact without having to do any type of formal lifting.
Wonderful. Thank you. Now, Jen, you're a breast cancer survivor who underwent breast reconstruction. Which recon option did you decide was best for you, and how did you make that decision?
It was pretty simple for me, actually. I was not a candidate for anything except implants. So I have implants. It did take me a few times to get it right, unfortunately. But my last plastic surgeon did a really amazing job. But in total, I had 4 reconstruction surgeries. Wow.
Are you comfortable sharing what happened with the first few that didn't work out for you?
Yeah, the first 2, you know, they just didn't look good. And, you know, it's so, I'm finding this whole conversation so fascinating because I had my mastectomy 5 years ago and it's already so different. It's unbelievable. I mean, I have scars going across, I have scars underneath, I have, you know, I have them all. But I just find that the whole art of it has changed a lot. My first set of implants was under the muscle. They just kind of look like hamburger buns, you know, stuck to my body. I didn't feel like they really even looked any sort of natural. I didn't understand what the point of them was. My second set of implants, they moved over the muscle and then they used ADM to kind of hold them up and create more of a pocket. But unfortunately, they kind of just fell. And now I had grandma boobs that were, no offense to any grandmas out there, they were too low, they were misplaced, and I'm very hollow on the top. I had a very radical mastectomy because my cancer was so high up on my chest that they went really like all the way up to the collarbone. So I looked very hollow and very kind of droopy, to be honest. So in my third surgery, everything was revised again, and it was much better. My fourth surgery is more of a revision where we changed the implant because my implant was too small. It wasn't fitting the pocket properly, and just doing a little bit more fat grafting. I had fat grafting 3 times.
And are you happy with the results now after your 4th surgery?
Yeah, I mean, it's the best I've looked so far. I think for me, my doctor was a godsend. I mean, he gave me life back, to be honest with you. It's amazing to me how much these surgeries really affect you mentally and physically. You know, everybody would always say, well, you look fine to me, you're having another surgery. You know, we as patients, we get a lot of slack and or flack, I should say, excuse me, chemo brain, flack from you know, a lot of our friends and family say, aren't you done? Aren't you like sick of having surgeries? And my answer would always be like, yeah, I am sick of having surgery, but also I'm sick of seeing what I look like in the mirror every day. It's a constant reminder of breast cancer. So now, since I'm much happier, it's less of a reminder for me, and it's a little bit easier to buy clothes and, you know, wear clothes. It really affects you in a lot of different ways that I think a lot of people don't understand.
Mhm. Yeah, I feel like, you know, people say plastic surgery could be a vanity procedure, but in this case, it's certainly not. It has such an effect on your self-esteem, on your self-confidence.
Yeah, and you know what, even if it is a vanity thing, who cares? You survived cancer. You deserve to look good.
Absolutely. And now, did you want to look as you always had, or were you looking for something different, or were you just trying to restore what you had before?
Um, You know, I don't know the answer to that question. And I'll tell you why. This is another thing I find so interesting. As I've been doing breast cancer advocacy work, and as I've really gotten to know like my plastic surgeon and all the different ins and outs of plastic surgery and breast reconstruction, I have a lot of things I would do differently if I was to do it now. First of all, I would find my plastic surgeon first. I didn't even know that that was a thing. And I hope that's a very big message we can get out there, is find your plastic surgeon first, because I didn't really know what kind of reconstruction I was in for. I was just sort of told, here, this is what you're going to do. And I said, okay, I don't care, just save my life. You know, so you're so panicked of like, who cares if my breasts don't look perfect? I just don't want to die. And then when you realize, you know, luckily in my case, okay, I'm not going to die from this, then you're like, well, wait a minute. Did I do the right thing? Did I pick the right surgeon? So there's just a lot of things that I would do differently if I was to do it now. I am about the same size as I was before. I'm a little perkier, and I might have a little bit more protrusion than I did before, because I was 42 and I had a couple of kids and I did breastfeed. So, you know, nature. But I just, at the time, it was just like, save my life, and then I'll think about my boobs after. And it's a mistake, I have to say. And it's really unfortunate that we are sometimes really put in a situation where our back is up against the wall, not by any doctors, but by disease, that we have to make decisions so quickly. I mean, I was diagnosed on July 12th, and my breast surgeon wanted to do a mastectomy on July 27th. I didn't even see her until July 19th, right? So I first get into a doctor a week later, and then she wants to do the mastectomy a week later. I pushed it a couple of days, but I mean, within a few weeks, I didn't have breasts anymore. So I was forced to make very quick decisions. And so I don't know if I even thought about that then. I would do it differently now if I could.
You know, Jen, the other thing that I just want to jump in on is that I think your message is so important. You know, to advocate for yourself when you're literally worried about your survival, you don't even have the foresight for that. And if you're bringing that to other people, I just applaud you, because of course, I think other surgeons would agree with me. I'm seeing patients, I'm the fourth surgeon often. And then I'm just like, you know, at my wit's end, because had the first surgeon done the incision in a different spot, or why was this decided on? And the patient's was not in a position of power to make choices at the time, but actually you are. You just don't think about it, and you don't want to be considered vain when you know, you're thinking about your kids and being there for them next year, right? So it's very tough.
100%. 100%.
So I love that that's your message, and you know, and I hope that all we can even give patients a list of what to ask. What's the rate of mastectomy flap necrosis in your hands, doctor? Do you know how to perform fat grafting? Hint: the right answer is, it doesn't work. Is not the right answer. Okay,
Yeah.
It does work in the right hands. You know, there's like a way to kind of screen people out that isn't, how many of these have you done this year, that you normally hear. You know, so I love that you're talking about this, because I think patients need to hear it. And then finally, with neoadjuvant chemotherapy, we're seeing a lot more people have the time and then this mind space to shop, right? Because they've got chemotherapy, you know, 6-8 sessions prior to their first cancer surgery. So then they're allowing themselves to say, hey, how I look is important. Thank you, right?
Yes.
I mean, and we're plastic surgeons. We all believe, of course, how you look is incredibly important. Like, you don't want to be hunched over and changing in the corner. If you go to a gym, you want to be able to walk naked through the locker room and nobody knows you had surgery. That is our goals. And we're trying to constantly push that bar up no matter what it takes. And that's not vanity, that's sanity. So, if we could get that message out to patients, it would be such a wonderful thing.
Yeah.
So thank you for doing that.
Thank you for saying that. And I really applaud you guys for really hearing your patients. My first experience with my first plastic surgeon, when I told him I wasn't happy, I said, I'm just not really sure that this is what it's supposed to look like. And he said to me, be happy you're alive. This is good as it gets. This is as good as it gets. And I will tell you something, and I'm a pretty independent, strong person. And I had chemo after my surgery. So I was just kind of a mess and broken down and tired. And I didn't advocate for myself right away. And it wasn't until the nurse said to me, off the record, go see another plastic surgeon. I mean, he was so difficult that I used to have to say to the nurse, please tell him to take it easy on me today. I'm having a tough day, or whatever it might be. He would handle me very rough. It was not great. And I really learned through this process about advocating for yourself and educating yourself. But I'll tell you, like I said, I'm 5 years out now and I'm still learning so much, and it's changing all the time. And, I was told I wasn't a candidate for DIEP flap. And now, thanks menopause, I've gained some weight. And now I'm like, well, maybe now I'm a candidate for DIEP flap, and is that better for me? And will it be more natural feeling? And will I be more comfortable, like you talk about changing in front of people or whatnot. I'm very uncomfortable with that now because I do, I don't look normal, let's call it, for lack of a better word. So I mean, I look great, but it's not, I've seen a lot of things that are, surgeries that are more passable as natural or whatnot. So I wonder, maybe that would be a better option, or maybe I won't get so many of these little like fake itches or nerves or, whatever it might be. So it's always changing. And for us, we always have to advocate and educate. And it's hard as a person who did not go to medical school to learn all of this, plus we are learning the oncological side of it. And, I'm going to my oncologist and saying, shouldn't I be on Lupron, or should I be doing this or that? So it's a lot of work for the patients, and we're just trying to survive. So, but I appreciate you really hearing the patients, because there's so much to it. Like you say, it's not vanity, it's sanity. There's so much to the mental health aspect of it that reconstruction is about, that it has nothing to do with what we look like.
Dr. Sahar, are most breast recon surgeries a one and done deal, or do they sometimes require multiple procedures?
Question, but I'd be hesitant to tell any patient that this is the last procedure you're going to have. Even if you have direct implant with nipple sparing mastectomy, which theoretically it could be one procedure, you always have the risk of potentially implant failure, leak, capsular contracture, asymmetry, some nip intacs, nipple positioning, but most in most procedure, like for instance, two-stage procedure where you put the tissue expander first, and then you replace it with permanent implant. That's 2 procedures, and then on top of that, with skin-sparing mastectomy, we usually proceed with nipple sparing nipple reconstruction, and that's a local flap procedure, which can be potentially done in the office, because after mastectomy, there's not much sensation because the nerves are severed. You could use lidocaine with epi mostly for bleeding control, and so that's another procedure. And then finally, tattooing for nipple areola. So there's and on top of that, for all procedures, there's always the risk of things change over time. Gravity affects the implants, asymmetry. Sometimes there's some dog ears that may have not been noticed initially, and capsular contracture is an issue. So I'd be hesitant to tell any patient that this is the last one, unless there are some patient, they just want the implant and they don't want to have nipple reconstruction. They just want to have a breast mount, and that's it.
Mm-hmm. Mm-hmm.
Yeah.
And Dr. Casalith, how early should someone consult a surgeon after a breast cancer diagnosis?
I think actually Jen touched on this. Find your plastic surgeon first. if I would advise one thing, it's find the people who have, let me first just say, sometimes people have a lumpectomy, right? So in that case, you're finding your general surgeon, your mastectomy surgeon first, or your lumpectomy surgeon in that case. Even then, it may be worth talking to a plastic surgeon, because a large lumpectomy can be a third, half your breast, and might very much change the way your breast looks. So right off the bat, it's a good idea to find your plastic surgeon, unless you have a tiny, tiny little cancer that you really don't need us for. And so you're looking for people that have great word of mouth, incredible reconstructions, incredible aesthetic results. And then I think we also talk about this, that are actually listening to you, and then take that moment to stop and hear what you have to say and what your story is. Because if I think if the plastic surgeon can't hear what you have to say, then how do they know how to treat you? Because there's plenty of plastic surgeons with opinions on breast and how breast should look. But what do you want your breast to look like? I'll get a patient that's a double D that wants to be an A, and I'll catch them with an A that wants to be a double D. It's not what I'm about. And if I tell the patient how they should look, well, aren't I just as patronizing as the next guy, right? So I think finding that person, even if you have to see a couple people, I think is important. And so right away is the answer.
Mm-hmm. It sounds like it. And now, Dr. Sahar, we're hearing a lot about aesthetic flat closures. Would you explain what that is?
Well, I mean, this is something that we generally, I haven't done. Usually when the mastectomy is performed without reconstruction, we're not usually called. But this would refer to basically a closure that is aesthetically acceptable. So sometimes when a mastectomy wound is closed without an implant, you can have some divots, some bumps. There may be contour irregularity. This can maybe wrinkly at the edges if there's too much excess skin. So the idea is to keep it flat, and so it heals well, and that's so there's not it also serves as a good spot for a external prosthesis.
Mm-hmm. Got it.
Although, Kate, I find that most people that want aesthetic flat don't really want breasts anymore, and they usually are not interested in a prosthetic. You probably come across that too. It's a group of patients that really don't care about breasts and don't really want breasts. They don't want to have an involved reconstruction. Why? Because they don't really want breasts. So it's a different patient population. And that person should not have a flat closure that has giant dog ears on the side and it looks bad. That's why the aesthetic got tacked in there, is because the general surgeons, guess what, don't know a lot about aesthetics, and they're doing the best they can. So often it's really good to bring a plastic surgeon in to aesthetic flat closure, or consider something called Goldilocks. So you have like a little bump out so things don't like ride up and fit funny. And you can have a no nonsense, low risk reconstruction and not gain another problem of having weird leftover skin parts and stuff. So even aesthetic flat should have a plastic surgeon in it, and understand this is a different patient group. They want something else, and that should be respected.
As a patient, I'll tell you that I agree with you 1,000% that it is the trend now for people who want aesthetic flat closure to use a plastic surgeon to do so. A lot of patients are finding that, unfortunately, certain plastic surgeons aren't really listening to them, and they say, oh, you might change your mind later, so I'll just leave, and then they wake up and they have skin left over, and that's not what they wanted. So I think that people that choose aesthetic flat closure have actually really thought about it quite a bit. And I think that doing it right the first time is always really important. So there is definitely a trend on the patient side of it to use plastic surgeons for flat closure.
Well, I think of the procedures that we do, I mean, it is technically challenging to close those mastectomy defects, particularly in someone who's large breasted. So I just feel like they lack the skill set, and almost mandatorily a plastic surgeon has to be involved. I mean, there is, in truth, it is difficult for some people to get a plastic surgeon involved because it's not always a procedure that insurance covers, incredibly enough, because they cover all sorts of these other procedures, including long flat procedures. But I think really we need to advocate more for those patients who want to have that procedure done, who know what they want. You know, they do. It's very clear when those patients come in what they want, and it's a shame that we have to fight that battle to provide it for them, because it's well within our skill set. I mean, people are very happy when they have that done, when it's done properly. And there's a big difference between it being done right and it being done wrong.
Mm-hmm. And even though you are, it's overly simplified to just say that you are tucking the skin in. So what would that procedure look like?
Yeah, it's more like a geometric arrangement. So it's not necessarily tucking it in, because sometimes you tuck it in, but you certainly don't want to like cross over, onto the other part. So we look at the chest and the breast as anatomic units, and then we try to best hide those incisions, the excess skin, into natural shadows, essentially. And that takes some experience, and it takes a lot of training, and it's just not something that the general surgeons will do. And by the way, I mean, I hate to be crass about it, but they're not paid to do it. So their interest in doing it is not there, which makes it really difficult as a procedure.
Right. And what should a patient expect when it comes to recovery from a recon procedure, or does it totally vary based on the specific type of recon surgery that a patient chooses?
Yeah, it varies. It varies a lot based on the type of recon. Yeah, but I think the shortest, we think for some of these oncoplastic reduction type procedures, the Goldilocks procedures, generally, I think that's about a week recovery from that. It might be a couple of weeks from an implant-based reconstruction, particularly if we're using drains. And I think Dr. Cohen can speak to the deep flaps, because that's really what she does most of. But I think that is maybe a 3-week, I tell people, recovery for that.
Dr. Cohen, would you like to chime in?
Guys, sure. In terms of if you're having a flap reconstruction, I usually tell patients that we typically keep them in the hospital anywhere from 2 nights is the goal. Sometimes it can be 3, and that they would expect to go home with a few drains, both in the belly region and in the breast region, which takes some caring, usually for about, say, anywhere between 5 to 10 days to have drains. And then afterwards, we encourage them to be up and walking right away, but it's a slow walking, and that they would expect soreness. In terms of average amount of time that they may be on pain medication, it's really a bell curve. It could be anywhere from taking prescription pain medicine, from not taking it when they go home, to taking it just at night for 1 to 2 weeks, to really taking it for a full week to 10 days. Everyone's different. In terms of recovery, I think it really is more of a 3-month period to really be able to feel like you're not thinking about your body, or things that you're feeling physically throughout the day.
Mm-hmm. Mm-hmm. And Jen,
I would like to add to that, for deep flap reconstruction, I would also restrict them from heavy lifting, especially if it's muscle sparing, or after pedicle flap, for reconstruction. And recovery is kind of a loaded word, depending on what people do. If it's office work, they can return sooner. If they're construction work, or if they're doing heavy lifting, then it's going to take them longer to heal. I mean, if we look at the wound healing from animal studies, once an incision is made on the skin, how long does it take for the strength to approach normal without the stitches? Well, it's kind of a sigmoid curve, and it takes about a month and a half, 2 months for 80% of strength to come back.
thank you. And Jen, what was your recovery like? And did anything about your recovery journey surprise you?
I like what you said about recovery being an interesting word and really being relative for everybody. I mean, for me, I had under the muscle first. So they cut my muscle, and then I got sewn back in when they went over the muscle. I still can't do a full push-up or a pull-up, or even sometimes open a door without pain. That's just the way it is. This is just life now. But I would say after my first surgery, my mastectomy, and I had tissue expanders put in, it was a really rough first 2 weeks. I would say that when the drains get taken out, I find that healing goes much faster after that. I don't know if it's mental or not, but the drains are really the hardest part of everything. I would say with fat grafting, the tenderness and the soreness can really truly last for months. I think that doing a sit up or whatnot is tough for a while. But I would say to people when they ask me, because I get this question a lot, when can I go back to work, or when can I drive my kids to school or whatnot? I usually say, don't plan anything for the first 2 to 3 weeks at all. And then after that, you'll start easing back into your life. A lot of us are busy moms and wives and daughters, and we have jobs and friends and social things, and we're busy. We don't have time to sit on the couch so much. So my other piece of advice for everybody would be, whatever your doctor tells you, please make sure you listen to it, because you only get one chance to really recover properly.
That's a really fantastic message, and so true, because if you aren't following the post-op instructions for your recovery, that impacts the success of your procedure. Dr. Casselith, let's say a patient has a lumpectomy in one breast. Should they consider surgery on the other breast as well in order to help them look alike, or what is the protocol here that you recommend to patients?
So much is about how much is being taken and then the patient's own attitude toward their breast. There'll be people where you can take a third of the breast out and they're like, I don't even care. Other people, if they see like a little 50-gram difference, that'll make them crazy. So you have to figure out who you're dealing with first. It's always smart to talk to a plastic surgeon, or if you have a good breast surgeon who can pull out this information from a patient, they'll avoid a lot of pain for themselves because they'll have someone happy with their work. Oncoplastic reduction is when a patient has a larger breast, and as the tissue is removed, we reduce and make the breast look like a nice smaller breast rather than it just lost the volume without the actual footprint of the breast changing. And so often, if the other breast is the same size, we're reducing both of them the same size, but one of them is a cancer operation, the other one is a symmetry operation. That's a great surgery done right. I'm sad to see that a lot of breast surgeons are doing it rather than a plastic surgeon doing it, because it's still, I think, very much an aesthetic surgery. I had a couple of like bat wing closures come my way that a general surgeon did. I don't want to ever see a bat wing closure again. Please bring your plastic surgeon in. Again, a good rule of thumb in our practice is if it's going to be 20% of the breast or more, bring the plastic surgeon in, because what we really don't want is a hole to form in the breast where the tissue is removed. Something called a seroma forms. And since people are radiated after lumpectomy for cancer surgeries, the radiation can also deform or pull in that tissue and makes it actually very hard to fix. And that's why we bring the plastic surgery in the beginning when there's no problem and can be done properly.
Mm-hmm. And Dr. Cohen, is nipple reconstruction common?
Yes. So in patients who have, just to clarify, who have had their nipple removed, so we call that skin sparing mastectomy, we do a wide range of nipple reconstruction. So if they're having a reconstruction with their own body tissue, meaning with a flap, meaning we're taking one part of their body and moving it to recreate their breast, typically that comes with an area of skin that is saved. And where the areola was, we then replace it with skin that is alive and part of the flap that's been transferred. And once that flap heals in, we then reconstruct a 3-dimensional construct out of your own new skin that has been taken from part of from the flap elsewhere. And so that is one option if patients want to have a 3-dimensional construct to look like and feel like a nipple that they've had in the past. Once that heals in, we then offer them the option to tattoo on top of the 3-dimensional skin that is now the new nipple, so that not only do they have the 3-dimensionality of it, but they also have the coloring. And oftentimes we'll try and have them take, we compare to pictures and coloring that they had before surgery. in patients who have had an implant-based reconstruction, the opportunity for a three-dimensional reconstruction out of their own breast skin that remains is often an option, but sometimes it's not, depending on if they've had radiation to that breast skin, or if the quality of the skin that remains after the mastectomy that is sitting on top of the implant is too thin or atrophied or scarred. And in that case, patients can have just a tattoo, or they can have a three-dimensional flap, which is called, there's many different ways to create that three-dimensional nipple. So there, it really depends on your type of reconstruction, the quality of your mastectomy, and the quality of the breast skin that remains afterwards. And then most importantly, the patient's own desire. Some patients don't want to have a three-dimensional nipple. They don't want to, you know, they say, look, I could throw a t-shirt on and never have to wear a bra. Some patients absolutely want that. And so we offer everything to our patients, but it's definitely, it's not a straightforward answer.
Mhm. And Dr. Talmore, what happens if a patient had, let's say, like an implant reconstruction, but the cancer returns? Would that implant need to be removed?
Well, it depends, it's a good question. It depends on where the cancer returns. So, in days of yore, which is, I guess, 5 years ago for Jen, but when the implants were placed under the muscle, it was most common for these cancer recurrences to happen very superficially, because the reconstructive part was separated from the mastectomy part with muscle. And so most often a recurrence would recur at the skin, essentially. And in that circumstance, a small recurrence could be removed and sometimes the implant left intact. Recurrences, by definition, almost always mandate radiation in addition to whatever local procedure is involved in removing the recurrence. So, that might be a circumstance in which, let's say you keep your implant and then you have radiation, but then you might want to switch out for autologous tissue, for flap, to alleviate the impact of the radiation. So, I'd say that traditionally the more common place to recur was superficially. Now it becomes a little bit more complicated, though, in sort of this prepectoral way of reconstruction, in which the implant capsule, the scar surrounding the implant, might actually be just adjacent to the area where the recurrence occurs. And in that circumstance, most oncologic breast surgeons would want to remove at least a bit of the capsule and then to address the revision of the reconstruction in some way after.
Mm-hmm. That makes total sense. And Jen, as we wrap things up, what do you think breast cancer patients need to know about reconstruction?
I would say, again, find your plastic surgeon first, for sure. I would say that it is definitely a staged procedure more than it's not. So, and that's okay, and advocate for yourself, and, to your friends and family that might not understand why it's so important to you. And I would say that even though I am grateful to be alive, and I am grateful that my life was saved, there is a difference between being alive and feeling alive. And if looking good is part of your feeling alive, then you should have no shame in that.
That concludes our panel on breast reconstruction. I'd like to extend a very special thank you to Jen Rosenbaum for sharing her recovery story with us, as well as Drs. Casseleth, Talmore, Cohen, and Sahar.